So, Sandra, I understand you've been referred to me because you have Bell's palsy and it's been going on for some time.
That's right.
OK. Well, first of all, I wonder if you could run through for me how this started, what treatment you've had and so forth. I have your notes here, but it would be good to hear it from your point of view.
Sure. It all began when my daughter was born. So that was, 8 months ago now. At first everything was fine, but after about 48 hours, I started to notice that my mouth felt funny. I realised I couldn't taste anything on the left side. I mean, it was strange. I could still feel my tongue okay, but that side of my mouth had gone sort of numb. At the time, I just put it down to tiredness. You know, lots of strange things happen to you during childbirth.
Indeed.
Anyway, when I woke up next morning, it had got worse. I looked in the mirror and I could see that the left side of my mouth was drooping, and my eye was the same. I didn't know what was going on, so I called my husband and he immediately rang for an ambulance.
Yes.
I mean, he thought I must have had a stroke or something. So we ended up in the emergency department.
I see. And Bell's palsy was confirmed?
After about 10 hours, yes. But I was told that this wasn't uncommon during pregnancy and childbirth, that I shouldn't worry. I was sent home with a course of steroids and told to go to my GP if it didn't clear up in 2 to 3 weeks. We felt quite relieved to hear that. I mean, it was uncomfortable, but they gave me some ointment to put on my eye and also some gauze padding to help me at night,
Right.
because I couldn't even close it properly. Anyway, I couldn't get on with that, but fortunately my local pharmacist was able to give me some tape, which did help me to keep the eye closed at night. But it was tough coping with all this and having a newborn baby at the same time.
Of course.
Eventually my husband had to go back to work and I was essentially looking after my daughter alone.
So did you go back to the GP?
Yes, I did, and he was quite surprised to find that I was no better. So he sent me for an MRI scan to make sure that nothing else was going on. And, I had a full blood count at the same time.
Right.
Anyway, nothing showed up, and again I was told that it should get better of its own accord, but that it might take up to 9 months. Well, that's nearly up now, and I know better, so that's why I'm here.
I see. And in terms of your current symptoms?
Well, as you can see, I still have the facial palsy, and my eyesight isn't always very good. It's sort of blurry, if you know what I mean. I actually fell down the stairs last week, and I'm sure that's why. I didn't hurt myself, but thank goodness I wasn't holding my daughter at the time. Poor kid, I'm not even able to smile properly. And of course I can't blink either, which leads to a lot of discomfort in my eye, which still doesn't close at night. I really don't feel my face is getting better. In fact, I think the muscles are getting tight, even on the other side.
I see. So your GP has referred you to me?
Yes. I went to see her because I noticed something else recently. When I try to close my eye, that side of my mouth moves as well.
Oh, yes, synkinesis, that's called.
Oh, right.
OK, well, thank you. That's helped me get an idea of what the problem is. Was there anything you wanted to ask me at all?
So, Declan, you've been referred to me because you've been experiencing digestive problems. Before I examine you, perhaps you could tell me in your own words the history of the condition.
Well, it all started about 3 years ago. I suddenly found I was having issues keeping food and drink down. So I went to the doctor and he said, well, what you're describing, it sounds like acid reflux. Well, I'd heard of that and I didn't think that's what it was. Anyway, he prescribed a course of H2 receptor blockers and said, just try, and if this doesn't work, then we'll schedule some tests.
And?
Well, I was right to be sceptical because they didn't work. So I ended up going for an endoscopy, and my GP was surprised. He said, you were right, there is something else going on. They'd taken a biopsy of my stomach, and there was a problem with the bacteria there. So he put me on a triple antibiotic, and I was on that for 21 days.
And did that help?
I did feel a bit better, but if I ate certain foods, they'd still get stuck in my throat. like when I was eating bread, that sort of thing. Then fast forward to this time last year, and I had the same episode again. I just couldn't keep the food down. Only this time, it wasn't only that. I also had a feeling like my stomach was burning. It was horrible, like my insides were on fire or something. I thought it would pass like the other symptoms did, but actually it just got more and more intense, so I called the hospital and the paramedics came out to get me.
So what happened there?
Well, they did some tests. They took a stool sample and they told me they were going to analyse that to see what was going on down there. Anyway, eventually I was told I'd been diagnosed with colitis and again was prescribed antibiotics. So I took them, but within an hour or two of taking those pills, I was throwing up again.
Right.
So I ended up back in hospital because I couldn't keep anything down and I was really suffering from fatigue. I was having trouble even standing at this point and basically everything hurt. So they admitted me and put me on an IV for fluids because I was dehydrated and malnourished.
And they did more tests?
Yes, this time they gave me a barium swallow test and took an x-ray of my chest area. What that showed was that I had a disorder in my esophagus. Basically, the endings of the nerve cells are supposed to move the food down my esophagus to my stomach, and so signal to my LES muscle to relax and allow the food into my stomach. But because these nerves aren't working, there's no signal and the muscle doesn't open.
So they diagnosed achalasia?
That's right. They told me I'd have to manage the condition somehow. I mean, that's okay because it's not all the time. I have these episodes where I can't keep anything down. Then for a while I'm okay as long as I'm careful. I keep to a mostly liquid diet or go for food that's easy to break down. I watch the texture of the solid stuff I eat and keep to small portions. Another thing that's helped is having carbonated drinks at mealtimes because burping helps to get the LES working.
That's right. OK, well, I think I've got the picture now. Next, I'd like to ask what you're hoping I can do for you.
Well, I was looking on the internet and I saw that there's a new form of surgery that's been developed that might make a difference to me. My GP said you'd be able to tell me about that.
OK, well, let's begin by analysing.
How are your insulin injections going?
OK, actually. I was a bit sore the first few times, but I found a really good place here on my thigh where the angle's just right. So I haven't needed the ice pack you suggested. The thing that's worrying me is shooting that first drop into the air, then throwing the needle away afterwards. I mean, that's so wasteful, and we're always hearing how the health service is strapped for cash.
Well, it's really important to make sure the needle's working properly before you inject yourself. Don't skip that bit because you really need that insulin. And don't worry about the needles. They're designed to be single use. One thing you do need to watch, though, you should vary the site of the injection. If you go back to the same place too often, the skin gets hard and doesn't absorb the insulin so well. So find a few good places and rotate between them.
Oh, yes, I remember you saying that before.
Good morning, Dr. Coles. Thanks for getting back to me. I'm Gareth and I'm a nurse on Ward C3. I'm taking care of your patient, Mr. Glover. He's a 70-year-old man who's here after a fall at home where he broke his hip. Are you familiar with him? Great. Yeah. The reason I wanted to talk to you is that there's been a bit of variation in his vital signs. His temperature's 37 and his respiratory rate's 16, but his blood pressure, that's 80/56, which is quite a bit lower than it has been. I held his BP medication this morning, but I was wondering if we could have parameters for when to hold it and when it's okay to give it. Also, he's complaining of feeling weak and tired, and he's asking when you're next likely to be doing your rounds, so I think he's aware of a change too.
OK, so when you're dealing with asthma patients, it's quite likely that they'll ask you about exercise, and you're going to have to make a quick assessment of what it's appropriate to say. Basically, by giving their lungs a regular workout, they'll cut the risk of asthma symptoms. But if they've never had a regular exercise routine before, the first thing they need to do is go to the GP for a checkup and make sure their asthma action plan's up to date. Most patients can fit some regular exercise into their week, and you should stress that little changes will make a huge difference. So simply just walking the kids to school or taking a walk in the lunch break instead of sitting down could make an enormous difference. Also, if they can find somebody they know who's willing to go with them along that journey, that'll help massively as well. But remind them that whatever they do, they'll always need to have their blue reliever inhaler with them.
So, that's all done. Was there anything you wanted to ask me?
Yeah, I've still got this big gap on the other side. I remember you said we might do an implant there too, but that it'd mean a slightly different procedure. If I remember correctly, you said that you couldn't put one there because of the bone, but that you could connect it to the tooth next door. Is that right?
Well, partly. What we discussed was what we'd do if you lost the next tooth along. So we'd have to extract that one.
Right.
Then you'd probably need a bone graft there so that we could attach 2 teeth to a new implant. The gap you're talking about is where you've lost a big molar.
Right.
We couldn't fill that gap completely using this technique because that'd put too much pressure on the implant.
I see. Well, you said the price would be much higher than the one I've just had done. I guess that's why.
Uh-huh.
Okay, we need to do our debriefing. Any comments about the case, Jackie?
Well, we were late getting started due to a delay in getting the surgical consent to come in, but I've talked to the junior resident and I think we just had a few crossed wires there, so it's sorted.
Yeah, we were busy in clinic this morning, but we were also delayed getting into this room because the case before us went over their time, which pushed us back. That's becoming a regular occurrence with that particular team. I'm going to ask our nurse manager to adjust their time slots based on the recent history of their cases.
We were also slow to get the portable films from radiology. There were several rooms requesting films, and radiology seemed short-staffed. That's unusual for them, but let's keep an eye on that, and if it happens again, raise it as a concern.
In bed 12, we have Liam Ogilvie. Liam's a 45-year-old male who was involved in a motorbike accident and was admitted with a frontal lobe contusion. He's broken his right arm and hand and has had surgery, including metal plates inserted into his arm.
Right.
He's also got deep grazes on his left knee and ankle and stitches on his right leg and shoulder. All dressings have been changed this morning at 9 and he's on self-administered morphine drip as well as an antibiotic drip. He's had injections to prevent blood clotting and his pain's quite manageable with the medication he's on. The doctors requested some observation and testing regarding memory loss, so that's priority this morning. His right arm's in a cast and he'll need regular monitoring and a physiotherapy sessions booked later in the afternoon. Somebody's coming to collect him at 4. I've just checked his vital signs and he's stable with blood pressure at 135/95. It's a bit up, so you'll need to watch that.
Today we're speaking to Dr. Kyle Munro, a critical care physician who went to Liberia as a volunteer in order to treat patients during an outbreak of Ebola. Dr. Munro, tell us a little about Ebola and explain your reasons for volunteering.
Sure. Ebola virus is a severe, often fatal illness. Without treatment, 9 out of 10 people who contract the virus die, many from dehydration, hyperbulimia from excessive vomiting, loss of nutrients due to diarrhea or organ failure. The disease was reaching epidemic proportions in some areas, so outside help was needed. The irony is that the necessary medical care is relatively simple by modern standards, and I felt a kind of moral obligation to go and ensure that it was provided. Saving lives might require as little as clean IV needles, fluids, and basic lab tests, things we take for granted in resource-rich parts of the world where they're at our disposal all the time. That isn't always the case in remote parts of Africa, where supplies can be scarce and the necessary expertise lacking.
And how did the patients you were treating respond to your presence?
Well, to give you some sort of idea of what we were dealing with, the first 2 patients I treated were a brother and sister. Both had developed Ebola symptoms, which often presents like flu, with fever and pain, and straight away they fled to the bush because they were fearful of what might happen to them if they were treated. They were found quite quickly because they were too weak to run, but even with treatment, both later died. Indeed, such was the fatality rate that 9 out of 10 people who entered our treatment facility were never seen again by their family members. So you can see what those attitudes were based on.
And is it true you had to wear a lot of specialised clothing while treating patients with Ebola?
Yes, that's correct. It's a little beyond the traditional white coat a lot of patients associate with doctors in a hospital setting. I would wear my scrubs, and then I would put on a pair of thick rubber boots that came up to my knees. After that, I had to get dressed in a bodysuit, then 2 pairs of gloves, a face mask, a hood that covered my neck, and finally goggles. The overall impression is similar to that of a spacesuit. In the tropical heat and humidity, it was suffocating. You lose about 3 to 5 litres of sweat, then spend the next 2 hours hydrating before you go back in. It does limit the level of care you're able to provide because it prevents you from physically contacting your patients, and that reduces the amount of sensory input we usually get as part of our jobs as physicians. But it also saves your life.
And is there a particular case that sticks in your mind for any reason?
Yes, one particular case involved a young girl, let's call her Emma. She was part of a small cohort of patients we had to deal with where someone in the family would test positive for the disease and someone else would be negative. And once a patient had tested negative, they had to leave the unit for their own safety. The little girl was 6 years old and she'd contracted the virus, but her mother hadn't, so I had no option but to escort her away. They were both terrified about what lay ahead of them. The girl died 4 days after they were separated, but her mother survived. I think, in some ways, this story really brings home to me just how awful things could be during this outbreak. You know, the kind of personal tragedies that people had to live through.
You're back home now. Do you think you approach your job here any differently now as a result of the work you did in Liberia?
That's a good question. I do think it's made me more sensitive to how important it is to make a real connection with your patients. One of the things we had to do for our patients in Liberia, in addition to just trying to blunt the worst effects of an appalling illness, was also to try and manage their anxieties and fears. I'd like to think that I'd been aware of the need to do that before, but now I think I understand the principle behind it in an entirely new way. And that's informing the work I do with my regular patients back home.
And do you believe Ebola is something the rest of the world should be more concerned about?
Well, I know the disease has spread further, and I'm not surprised. In a recent case in Nigeria, a man infected with Ebola collapsed at a crowded international airport. He later died, and the authorities had to closely monitor nearly 60 people he might have come into contact with. The majority of people think that Ebola is a dramatic disease that kills people in no time. The reality is that the incubation period is 21 days, and because the disease can spread from one infected person to another person via direct contact with blood or body fluids, the potential for spread outside of West Africa is there. Good infection control should prevent this happening.
My guest today is Gary Princelet, who's a speech and language therapist. First of all, Gary, I think there's a bit of uncertainty out there about what the work of an SLT actually involves, and it can vary. So tell us exactly what you do.
I'm a speech and language therapist working with adults in an acute hospital. I carry out communication and swallowing assessments, recommend safe consistencies for people with conditions like dysphagia, and I make referrals on for people who need ongoing help once they're discharged. A lot of people don't realise that we assess a range of things as well as language, but esophageal assessments actually account for the vast majority of patients on an acute caseload.
How did you get into this type of work?
My mum had a stroke when she was in her 20s, so I grew up with someone who had a communication disorder. She was really inspirational because she was working as a dentist before the stroke, but
Right.
had to retrain to use her left hand when she was left with right-sided weakness. My son's learning disabled too, and our struggle to get a speech therapist was the final push I needed to look into training as one myself.
Right.
It wasn't the career path I'd originally planned for myself.
So, what type of training did you have?
It's a degree-level job, so I went back to university as a mature student. I could have done a 2-year MSc because I'd already got a degree, but I chose the 3-year BSc so that I could still have a life. The 2-year Masters is very full-on. In the UK, the best way to get a job afterwards is to sign up to NHS jobs and apply for everything.
Right.
It's been a lean few years for SLT jobs in the UK, but it's quite cyclical, so I expect the situation to improve. There are some private jobs going too, which can be good as long as there's mentoring in place.
Describe a typical day in your job.
I get in at 8:30 and we go through what we call the list, which is our daily caseload and when they need to be seen. As well as current patients, there are new referrals every day, so they get divvied up. Then I spend a few minutes plotting my route through the day, prioritising who I need to see and when they're going to be free to see me. Then I go onto the wards and do my assessments and reviews. I stop for the ward's protected lunchtime between 11:30 and 1, catch up with my admin, then see more patients in the afternoon. I'm still doing my dysphagia training, so I have to report back to my supervisor quite regularly.
And what skills do you need for this type of work?
I think you need to be a good communicator and listener, and
Right.
being observant helps. But above all, in a hospital setting, there's no room for lone wolves. We work with other therapists like physios and occupational therapists, for example, as well as nurses and doctors, and we have to work together to find ways to fit all the pieces together so that the outcome for the patient and their family is the best possible.
Right.
But you do get bad outcomes in an acute hospital because your patients are sick and sometimes they don't make it, despite the best efforts of everyone involved in their care. So you've got to be prepared to take that too.
What advice would you give someone wanting to break into this career?
If you want to pursue a career as a speech therapist, you need to get some experience under your belt. Some therapists will let prospective students shadow them for a day or two, though hospital departments generally won't allow that unless you have a firm offer of a place at university. But there are opportunities to volunteer with support groups and charities, so that's probably your best route. The local stroke support group took me in and were really welcoming. It's also a useful way to see if it's the right fit for you before you invest too much time in it.